I'm Jimmy Bowen, one of the pediatric chief residents. This morning, I have the privilege of introducing Dr. Elisabeth Rosenthal. Dr. Elisabeth Rosenthal is the author of the New York Times bestseller, An American Sickness, How Healthcare Became Big Business and How You Can Take It Back, which was named a notable or best book of the year by NPR, the Wall Street Journal, and the Washington Post. She spent 22 years as a reporter, foreign correspondent, and senior writer at the New York Times, and remains a contributing opinion writer for the New York Times opinion section. In 2016, she left her New York Times staff job to become editor-in-chief of Kaiser Health News, a new independent award-winning investigative newsroom based in Washington, D.C., which focuses on health and health policy and publishes print and broadcast stories in hundreds of media outlets nationwide. She was named one of the 100 most influential people in Washington, D.C. in 2021 by Washingtonian magazine and does a monthly segment on NPR about medical bills. She has won many accolades for her writing, including the Online News Association Award for Topical Reporting, as well as the Polk Sibu Scripps Awards and the Osborne Elliott Prize. She went to Harvard Medical School after completing 2 years as a Marshall Scholar at Cambridge University. Finally, she worked as an emergency room physician at New York Presbyterian Hospital before converting to full-time journalism. It is my privilege to introduce Dr. Elisabeth Rosenthal.
Dr. Rosenthal, you're muted.
Hi, that better? Thank you, and thank you all for having me here. I'm sorry this can't be in person, and maybe it could be by now, but let's get going. I always like to start off these talks before talking about the topic of this presentation by telling you a little bit about how I got here. I, like many of you, went to medical school, trained in internal medicine, and was working in a New York City emergency room in the 1990s. And I'd always loved writing on the side. So I had been doing a lot of freelance writing. And what got to me was that so many of the problems I was seeing in the emergency room, even then, and it was really at the height of the HIV/AIDS outbreak in New York, were not medical problems. Like I could, give someone a drug or sew up a wound, but their problems were system problems, particularly if they were poor or uninsured or poorly insured. So, it started bothering me. And then when the New York Times, which I'd been writing for occasionally on a freelance basis, said, do you want to come over and write about this thing called the Clinton Health Reform Plan? I somewhat naively thought, well, sure, I'll go to the New York Times. I'll write about this Clinton Health Reform program. The medical system will be better, and then I'll go back to being a doctor. And of course, that Clinton Health Reform Plan never happened, and I never went back to being a physician. But what I did in the meantime really informed what led me to write this book. I spent a number of years overseas, about a decade, where I experienced a couple of different countries' health systems. So I'm a lifelong jogger, and but somewhat accident prone. So I had a few little accidents that needed treatment in different countries. I was in Stockholm. I was covering environment and fell and broke my wrist. And so I needed, obviously, to see an orthopedist. And with my super duper New York Times foreign correspondent insurance, I went to an orthopedist there at a fancy hospital who examined my wrist, x-rayed it, put it in a splint, and apologized profusely for having to charge me $400 because I was not in this Swedish system. So that was my kind of marker number one. 3 or 4 years later, I was doing a story in Rome and ended up hitting a tree and having a big gash on my head that needed stitches. And it was a Sunday morning. So I called an Italian friend and said, where should I go? And he said, well, go to Gemelli Hospital. That's where the Pope goes. And I thought, okay, good enough for the Pope, good enough for me. And they put in 10 stitches. You still can't see the scar. And And then again, apologized profusely for having to charge me 110 euros or about $130. So, those were my markers when in 2007, I came back to the United States at the age of 50 and needed that entree into middle age, my first screening colonoscopy. And I had heard while I'd been overseas for 10 years that American medicine had gotten really expensive. So I went to my HR department and said, how can I get a screening colonoscopy that for free, meaning for free to me, not thinking about the system, of course. And they said, oh, all you have to do is you go to one of these places that's in our network. And of course, I looked at the network list. One of the places was Sloan Kettering, Memorial Sloan Kettering Cancer Center. They run a screening colonoscopy clinic. And I thought, great, I'll go there. I trained there. I knew it was a good place for screening for cancer. And I was a little confused when I arrived on the day of my test because, suddenly this test that I had seen done as a medical student in a doctor's office, I was going to the admitting office. I was having a little wristband put on. I was, having an IV put in. I was put in like a surgical gown, had a surgical bonnet, and was wheeled into this operating room at Sloan Kettering. And I thought, wow, this is weird. And there were all these doctors and nurses in scrubs going around. And I was a little confused, but I thought, oh, well, my gastroenterologist was there. And then I got my push of propofol and, everything was great. And 2 hours later, I awoke to a clean, bill of health from my screening colonoscopy and didn't think much more of it until about a month later when the EOB came. And I saw that the hospital had charged about $12,000 for that screening colonoscopy, which seemed a little excessive. And I saw to my surprise that most of that $12,000 was for a facility fee for an operating room that was totally unnecessary for my screening colonoscopy. So of course, my happy insurance EOB at the end said, you pay zero because it was covered, and told me that Cigna, my insurer, had on my behalf negotiated the rate down to $9,000. And I guess most people would have been happy to see that little zero, but I was pissed because I knew, as you all know, that, there's no reason a screening colonoscopy needs to be done in an OR and charged $9,000 or $12,000. And our system will be bankrupted, and many people along with it if that continues to happen. So that got me obsessed with, why everything in US medicine costs so much. And when my editor at the New York Times said I was on the investigations team, came back to the investigations team, he said, what do you want to do? I said, I want to do a series on the high price of American healthcare and why things cost what they do. So, he was like, well, okay, I guess, but everyone knows it's expensive. And I'm like, yeah, I know everyone knows that it's expensive and everyone accepts that, but why? Why do they accept it? And why is it that way? So anyway, that he greenlit the series, which became a series called Paying Till It Hurts, which went on for 2 years and won a bunch of awards. And it really looked at not the the $1 million cancer care. It looked at the ordinary things that every American could relate to that just cost so much more in this system than they do in every other country. And of course, now you know why that series started off with screening colonoscopies. Much to the horror of the New York Times photo editor, who said, what am I going to put on the front page for that? They managed. We did a little chart. And it went on to look at things like getting stitches in an ER, asthma inhalers, getting an echocardiogram. And just the thing that was amazing is we did something that a lot of journalists do now, and we use it at Kaiser Health News to good end, is we put call outs at the end of the articles and said, do you have any bills that are kind of confusing or high or befuddling? And we were just inundated with responses from Americans all over the country, close to 20,000 in the end. And they were like, if you read through the comments, and it was really like a litany of all the flaws of American healthcare. So when that series was done, I felt like I wasn't done. You know, newspaper series, they have 10 parts, they win awards, and then your editor says, okay, time to move on to something else. But I couldn't let go. And I'd learned a lot of kind of first level things. I knew why, for example, screening colonoscopies had gotten so expensive. It was because of the addition of facility fees and anesthesia charges, things like that. But I was like, how did the US get to have something like a facility fee? Because I can tell you, when I called as a New York Times reporter, people in other countries to ask about the price of colonoscopy in Germany and Switzerland, for example, because I felt those were kind of demographically somewhat comparable countries, they said, you know, $500, $600 all told. And when I asked about the facility fee, the universal answer I got was, what's that? You know, you can't do a colonoscopy without a facility. How can you bill for the building? And so that set me off. I decided at that point it was time to leave the New York Times after 22 years and to write this book, which I'm going to tell you about. And I'm hoping that the first part will make you angry at some of the ways and some of the things we've gotten to in American medicine. And I hope the second part will give you ideas of things you as physicians and young physicians can do to make it better for your patients. Because I assume, like me, most every doctor went into this profession to make things better for the people they care for. And while they're doing that, not to bankrupt them or leave them with bills that mean they can't send their kid to college or something like that. So I'm going to try and start screen sharing and tell you a little bit about some of what I found. Okay. I hope we're good now.
Looks good.
Okay, so this is the book. It came out in 2017. I was hoping actually that it would be irrelevant by now, that everyone would just do what I said in the book and then the system would be better and it would be out of print. But for better and worse, it's still selling. And for better, I think we now have an administration that has promised to make some important moves to make the system more equitable, accessible, and affordable for patients. Okay, so basically where I came down after researching the book, and you know, I had steam coming out of my ears through most of my writing after I discovered how we got to where we are, is everyone says the US healthcare system is a market-based system. And I thought, okay, well, if it's a market, these are its rules, and they're pretty horrifying. And you can read them here, but the one that everyone always goes, oh, no, that's not true, is number 2, a lifetime of treatment is preferable to a cure. And really what I came to conclude at the end of the book is that what we do in American medicine today is determined largely by the finances, what will be profitable, what will add revenue, not what is good for the patients. And, you know, I don't want to say, I mean, healthcare has to be a business. When I was in training, it was a terribly run one. It had to be more efficient, but the business has to be on the back seat and the healthcare has to be on the front seat, what's good for patients. And right now that's totally reversed. And I think we need to change that. And just to give you a little bit of proof, I always like to point out there are people who have been working for many years for a cure for type 1 diabetes. There's a woman at Harvard, a researcher at Harvard named Denise Faustman, who's been looking at using a very old drug to basically turn on those islet cells that turn off in type 1 diabetes. She's had success in mice, did a phase 1 trial with patients, which showed some success of kind of waking up islet cells. And she thought, okay, now I'm going to go to the people who normally fund diabetes research in this country and see if I can get money for phase 2 trials, because that's much more expensive. And so she went, who do we trust to fund diabetes research now? It's the companies that make insulin and monitors. So she went to some of them and presented her research, and their response was, wow, that's really interesting. But if this works, you have ruined a $20 billion industry. If people don't need insulin and monitors and pumps, we're done, right? So why would those people want a cure for diabetes? I mean, I think we're seeing it play out in a much smaller way now in the debate over whether we will need a COVID vaccine booster. Pfizer says yes. The CDC and Dr. Fauci say no, at least not yet, and probably not everyone, maybe people who are older or immunocompromised. But Pfizer wants that booster because, yes, they believe the science, I think, but also they know Pfizer has projected this year they'll make $26 billion from their COVID vaccine. And they want more. Their primary commitment is to their stockholders, not to you and me. And that's a problem. Okay, so a couple of horror stories from my book very quickly. And this is a guy named Dr. Jeffrey Kibby. He's a teacher in the New York City school system. He has psoriatic arthritis. I don't have to tell you all what that means, but when he was in graduate school, he was very disabled by this condition, used crutches, had mornings where he couldn't get out of bed. And then came along a bunch of new drugs, disease-modifying therapies that were magic for him. He had started on Remicade, and suddenly he could walk, he got married, had a family, took a teaching job. And he'd been getting his Remicade infusions every 6 weeks at a downtown hospital in New York City. And it was costing $19,000, which, in today's medicine, no one blinks an eye. I always like to point out when I say that Dr. Kibby's infusions cost $19,000 a pop, that when I was a resident, the first HIV/AIDS drugs came into being, AZT. It was life-changing, life-saving for those patients. Before that, I watched many, many, mostly young men die very quickly from AIDS. And when those drugs came onto the market, they were priced at $10,000 a year, or about $700 a month. And everyone was outraged, like, how could you charge so much for a drug? Just my point of reference to say how much our bars have changed for what drugs are worth and what medicine is worth. So what happened to Dr. Kibby was that his rheumatologist moved uptown to a bigger hospital where she thought, a slightly more academic institution, and I don't like naming names, but you can see it in the back of the picture, NYU Langone. And suddenly Dr. Kibby went there for his next infusion, and suddenly the infusion that had cost $19,000 at one hospital, he was paying his insurance was paying $110,000. And he was like, what gives? So he tried to go back and forth with NYU, didn't get anywhere. And so he called me. And I tried to go back and forth with NYU and say, why does it cost so much? And their answer was, well, he's a big guy. And I'm like, yeah, he's a big guy, but not, 110,000 big. I got all sorts of runarounds. And I called Dr. Kibby back because I'm like, I try and be very careful as a reporter, and I like, tell me, did anything happen differently in this infusion room? I thought, maybe he had an anaphylactic reaction or they needed to do something special. And he said, yeah, there was something different. And I was like, oh, so there goes the story. There's nothing here. There's a reason for that big bill. He said, there was free Wi-Fi and cookies. And I'm like, okay. So what we pay for in American medicine, the difference between a $19,000 infusion and a $110,000 infusion is free Wi-Fi and cookies. We got to change that. This is a story about how hospitals have become more like hotels. I got a note as I was writing the book from a pediatrician, actually a wonderful guy named Frank McCullar, who was retiring from Providence Hospital in Portland, Oregon. And he wanted to talk about the changes he'd seen during his career. He had he'd done a peds residency in New York, but decided to come back home to Oregon to practice. He was not a particularly religious person, but he said in the 50s, when he started practicing, there were still nuns in the emergency room at Providence. And he said more than that, he loved the spirit of caring, of taking care of anyone who walked in the door. And, the commitment to patients first. And he saw that change over time. And I saw the leading edge of that when I was working as a physician in the 1990s. Suddenly there were people with clipboards going around saying, why do you need to, why do you need to admit that patient, or you need to admit that patient? The doctors he worked with in the peds clinic were all suddenly given reports about how many RVUs, relative value units, you know what that means, billing units, they were generating, with the implication being it's better to bill more RVUs. Then he said the doctors who weren't billing a lot of RVUs were given like courses about how to bill more RVUs. For example, he was told, look, when you saw that kid, if you just, listened to his lungs, you could have billed for a level 4 visit instead of a level 3 visit. And he was like, yeah, but the kid had a hurt ankle. Why would I listen to his lungs? Well, of course, the why is because it's better for billing. And then he described them all having to go what he called charm school to make sure their Press Ganey ratings got improved, because of course that matters a lot to hospitals. And then he watched the hospital start to build, which I'm sure you have seen too. And he said suddenly everything was spiffied up and spiffied up again and again and again, till in the end he said Providence Hospital looked more like the Providence Hilton than Providence Hospital. It had fountains stocked with jumping salmon and things like that. And it made him sad because he said it felt like medicine had lost its sense of mission, which is why he had gone into the field. So if any of you want to look at this, I can, I'll send around a link to Colleen later. This is a little quiz we made at the New York Times to talk about this phenomena. It's called, Is This a Hospital or a Hotel? There are 12 pictures, and you can decide, are they pictures of a hospital or pictures of a hotel? And just FYI, this is one of them. This is a small hospital in New Jersey. And my point is this is not a good way to spend our healthcare dollars. If I want to go to a spa, I'll go to a spa. And I'm not saying hospitals should resemble prisons, but I'm still waiting for someone to come up with like a bare bones hospital, because that's where I'll go, one that just delivers really good medical care in a clean, comfortable setting. I don't need jumping salmon and fountains. The book looks at all parts of medicine, and I think when people always want to say, who's responsible for our crazy health system? And, some people want to go, oh, it's pharma, it's insurers, it's the physicians, it's, but the thing is, to me, the PBMs, and to me, it's everyone in the sense of, including the patients. The system feeds on itself, and it's like a circular firing squad when you try to assign blame. So this is the fellowship pledge that a colleague of mine got signed in 1992 when he joined the American College of Surgeons. Sadly, this doctor has since passed away, but he found this and sent it to me. He particularly focused on the line that says, I'm trying to read it here, I will set my fees commensurate with the services rendered, that part of the pledge. And he was like, what doctor can say that these days? I will set my fees commensurate with the services rendered. And we routinely at Kaiser Health News get sent bills for stitches by a plastic surgeon from an emergency room that run into the $20,000, $30,000 level. Is that commensurate with the services rendered for suturing a simple cut? I think not. So I started looking into this and started looking at the current fellowship pledge that surgeons must sign. And that pesky clause, I will set my fees commensurate with the services rendered, was removed in about 2003. And I understand that most doctors, or particularly if you work for a hospital, you don't set your prices, but you should have some say over them. And that's where we're going to get to in the second part of the presentation. So when healthcare became a business, there were many doctors. When I was a physician, I was on salary from New York Presbyterian. So I was not particularly into the business of medicine. But once medicine became a big business, many specialties and many physicians became very entrepreneurial. Not all, but some. And it gave the profession a kind of bad name. So I don't want to pick on ophthalmologists, but one of the gigs that the ophthalmologist settled on was this thing, upgrades with a femtosecond laser. So basically, in the early 2000s, ophthalmologists had a problem. Their bread and butter had been doing cataracts, and cataract surgery. The reimbursement rates were going down because Medicare ties reimbursement rates to how long it takes to do a procedure. And the procedure had gotten simpler and simpler over time. So, in the late 90s, there was LASIK that came into the rescue to generate new revenue. But if you wanted to make a lot more money, you needed to do something. And this is the something that they did to improve their reimbursement for cataracts. Medicare will only pay for basic cataract surgery, which works perfectly fine. But they allowed ophthalmologists to offer all their Medicare patients upgrades. Like I can be offered an upgrade to business class, which I usually decline because I don't want to pay the extra money. But the upgrades for cataract surgery were two things, and one of them was using a laser. And so the story in the book is about a woman named Barbara Benion who went to get her cataracts done. And the ophthalmologist said, yeah, I can do the basic stuff for you and Medicare will pay, but don't you want the really good kind, the upgrade with a laser surgery? Now, that sounds really cool. Research has never shown that for most people, using a laser versus a conventional scalpel matters at all. But the upgrade for each eye would cost an additional $2,000. And, of course, Ms. Benion said, well, which is best? And the ophthalmologist said, oh, the laser is best. And so she agreed to pay. But then her daughter-in-law is a nurse in an ophthalmologist's surgery center in a different state who said, no, don't pay for that. That is not worth it. So she declined. But I guess the question is, what's the business model here? Well, the company that makes the lasers, at first someone said, no, this will never work because these things are very expensive. Individual offices can't buy these femtosecond lasers. They only existed initially at the big eye institutes. But the company that sells them, or companies, now got creative. And what they did was say, okay, we will rent you machines for the morning so you can offer femtosecond lasers to your patients and get the revenue for upgrades. And you can even charge click fees for how many times you have to click the laser to activate it. And it even came with a little helpful hint brochure about what you have to charge for the upgrade and how many you have to do to recoup your return on investment, right? And that should not be a doctor's metric for what they do, return on investment. And this is my problem. The metrics of success in medicine are patient health, patient happiness, how well do you feel, have you cured a disease? The metrics of success in business are return on investment, profit, and sometimes they overlap, and we should be happy when they do, but oftentimes they don't. And again, I think the healthcare metrics should be the ones that prevail. This is another example of that. I don't know if any of you have encountered a patient who needed Duexes. A guy who was an accountant for the city of Houston, sent me his query like, I had a hurt knee and my doctor just prescribed this thing called Duexes. And I went to the pharmacy and I was told it costs a lot of money and my copay is $250. What is this thing? So I looked. Duexes is a combination of two over-the-counter drugs, ibuprofen and famotidine, Motrin and Pepcid. So I figured out, like, what would it cost to make a kind of do-it-yourself Duexes at Target? And the answer was, about $11 a month. But this is what Duexes, with a free coupon, costs for 1 month in the United States. And people buy it and people prescribe it. And why? I think because when drug reps come to a physician's office and say, I've got this great new convenient thing, if you take all this ibuprofen, it'll upset the stomach, so you need some of the Pepcid. And the doctors don't know to ask, well, how much does it cost before they prescribe it? I think physicians are mostly shocked when they hear how much the things they prescribe cost. And I think this is one of the things you can do. Okay. Likewise, I wanted to focus, because we get a lot of bills on this, about ambulances, ER docs, even neonatologists are often groups owned by private equity now. They're out of network. I can't tell you how many bills we get from women who deliver at in-network hospitals. Unfortunately, their baby has some problems at delivery. They need to spend a few days in the NICU. They've done all their homework. They knew that their OB was in network, the anesthesia was in network, but the neonatologists, the people with the little fuzzy bears on their stethoscopes, were out of network. And the bill came to, in one case, $70,000, and the insurer wouldn't pay. Okay, that's what we now all call surprise billing. There is legislation to try and end that, but it's not really clear what will happen at this point. And it's just such an outrage, it shouldn't have taken 5 years to end. Okay, so this is the lesson today. Business considerations govern our healthcare, and your patients need protection. So I know most of you didn't go into medicine to protect your patients from the business of medicine, but it's now part of your job. And to give you a couple more examples, if you're not convinced, we had, with NPR and CBS this morning, we at Kaiser Health News have for the last 3 years now, going on 4, done our bill of the month. These are all patients submitted. And each one makes you angry. This is the story of a young woman who had some back surgery. She was given some narcotics after the surgery in case she needed them. She took 1 pill, didn't need any more. But at her 6-week follow-up visit, the physician said, or the surgeon said, oh, because we gave you a prescription for narcotics, we need to do a urine test to make sure you're not abusing them. And she didn't think anything of, she peed into the cup. And lo and behold, a few weeks later, she got a nearly $18,000 bill for that urine test, which that urine was tested for every drug under the sun and then some, and it was out of network. She was expected to pay because it was out of network. She was young and kind of afraid. Elisabeth Moreno is her name. She was still a grad student. So, after about 6 months of threatening calls and collection notices, she called her dad, who's in the picture with her. He's a physician. And even he was so intimidated by these letters that he called the lab and negotiated to pay $5,000 for his daughter, just so it wouldn't trash her credit rating. But peeing into a cup is not worth $5,000, and it's not clear that that test was needed anyway. Likewise, this is a 40-year-old guy in Montana. That's his wife, who is a physician, right? So even physicians can't solve these problems for their families. Sovereign was feeling weak, crummy, was diagnosed suddenly, was a healthy, he's a trainer, was diagnosed with end-stage renal disease, needed emergency dialysis. As we all know, Medicare covers dialysis after, I believe it's a 90-day waiting period. But in those first 90 days, the dialysis centers will take whatever money they can get from patients. So that's their opportunity before the Medicare rates kick in. Sav's wife, who is a physician, tried to find an in-network dialysis center in Montana. There was none. So she said they gave her the okay to go out of network, but DaVita didn't see it that way, and they got $500,000 of bills. And the last thing, and this we saw happening a lot during COVID. This is a woman from New York who had a head cold, went into her in-network doctor, her PMD, who said, I think we should just take a throat swab. We want to know what this is. Is it COVID? Is it strep? Is it influenza? Again, sent to a private lab for nearly $28,000, including the doctor's visit. And the insurer pays. And, if you're expecting the insurers to control this, they won't. They will control it in a minimal way, but they don't really care. What they will do instead of arguing over the price of each individual bill, which they don't have time to do, is just increase copays, increase deductibles, increase premiums. And that's why we see year after year after year, those numbers going up and up and up. Because, when I called an insurer who had charged $113,000 for an out-of-network assistant surgeon and said, why do you pay this? Why are you paying this bill? They said, it's just too much trouble to argue with them. As long as it only happens now and again. We have no contract with these out-of-network people. We'd have to bring in lawyers. We'd have to bring in investigators. It's easier just to write the check. As someone said to me, the insurers are too big to care about you. Finally, before we go into the what you can do segment, which I will have to speed through, I wanted to point out something we at Kaiser Health News did for the Washington Post. This is about the University of Virginia Medical Center, but it's happening at a lot of hospitals. We were pretty horrified to discover that there was a court in Charlottesville, Virginia, that one day each week did nothing other than lawsuits brought by the University of Virginia Medical Center against patients who couldn't pay crazy bills. It sued, I can't remember the number, I think it was almost 100,000 patients in a short number of years. They seized paychecks, tax refunds, put liens on homes. They even, and this was the most outrageous to me, one of the young men who had ulcerative colitis was a student at UVA undergrad, and he was admitted to the hospital, came out with a $5,000 bill that he had to pay for out-of-network doctors in the hospital, and they would not let him re-enroll in classes because he couldn't pay that bill. So, we need standards and practices in billing. Okay, so what can be done? We're going to race through this. Everyone has power to do much more. So I think doctors have to be more activist. If you see something, say something, bring it up to your administrator, complain, make noise. This is a guy named Dr. Barry Lindenberg and his patient Antoinette Newell. This was a minor thing, but her digoxin, which she'd taken for years, suddenly went up in price by about 1,000%. Now, for her, it was minimal difference in terms of, a $2 a month outlay versus a $10 a month outlay. But she was pissed and confused. She sent that to us. It turned out that generic drug makers who were making digoxin had all just raised their prices. And since everyone was doing it and getting away with it, they were all happy. The market this is a classic example of market failure in the US. Just having a number of drugs in the same category, or a number of drug makers who make the same drug, doesn't bring down the price. We have what's called sticky pricing. If they're all doing well by it, you see all these ads for type 2 diabetes, Januvia, Ozempic, and more, that are very, very expensive. No one wants to undercut the other on price, because even if you get a small fraction of that population, you're doing really, really well. Okay, so what you can do, help your patients find high value care. And what do I mean by that? Now, when I go to my doctor, he's like, okay, I'm going to send you to, because my doctor still is at New York Presbyterian Hospital, I'm going to have that test sent to the New York Pres lab. And I'm like, no, I want to please send it to Quest or LabCorp. His computer is programmed to send it to New York Presbyterian. But hospital labs are often very, very expensive for routine tests. I found one in the book. A vitamin D test, which cost $17 at Quest, was $774 at Albany Medical Center. So be careful where you order tests. And override what your hospital computer tells you to do, because that is often just directing money to the business. I always tell people at hospitals, and I know this is a big ask, and maybe you don't have the power to do it, demand that your hospital put prices on order sheets. So when you check that little box for vitamin D, you know what the hospital is charging for it. And if it's outrageous, I know as a doctor, as an ER doctor, I often checked some boxes that I was kind of ambivalent about, or I knew a patient could get on the outside. Know the price so you know whether you should tell your patient, yeah, we need this MRI now, or you'd be much better off getting it as an outpatient where the price will be a fraction of the cost here. Okay. Now my slides are not advancing. There we go. Okay. Patient education at the hospital. I'm sure this happens at UPMC. It happens at every hospital I worked at, and now here in DC where I live. Patients, when they come and get a little form that, well, they get a million forms, but one of them is a little thing that says, I agree to pay for everything my insurance doesn't cover. I want those forms changed, and I always add in a change myself. The form says, I agree to pay for everything my insurance stuff doesn't cover. I always add, so long as it's in my insurance network, because I think that is only fair, and that's how those forms should read. So again, when you're admitting a patient from the ER, I think, admitting will often say, oh, we're going to hold that patient on observation status rather than being truly admitted. Push back against that, because what happens when someone is under observation status, the outpatient terms of their insurance kick in, which mean much larger co-pays, much larger co-insurance. They can be left with bills easily in the thousands of dollars. When my mom was in an ER in New York City, and they handed me, they said she was being admitted for observation, I was like, no, she's being admitted for real. And, it worked. And the doctor really worked on my behalf to make that happen. When you refer someone for surgery or a procedure, insist that the surgeon and anesthesiologist be in network. This one really makes me nuts. When a kid of mine had surgery, I called the hospital and said, oh, will the anesthesiologist be in network? They said, oh, well, we don't know. And I'm like, we can't guarantee that. And I'm like, really? Because you know which anesthesiologist you assign, and you know which one takes Cigna. So why isn't it on the hospital to do that? Push UPMC to make this happen. This is a funny little story I did for the New York Times last year. My husband had a bike accident, was in a hospital for 3 days, and the bills were outrageous. I mean, it was insane. He had a little finger splint on a broken pinky, which was the least of his injuries. And it was digging into his finger, and it was uncomfortable. So they had him come back into the outpatient surgery clinic, and they cut down the edge of the splint. That was billed for about $1,500 as surgery. Now, since when is cutting a splint surgery? Very abusive. I think we need a new patient bill of rights, no referral to collections while bills are under dispute. We need to have limits on seizures and liens. I'm hoping that the new administration, maybe through the Consumer Protection Bureau, can do something about this. We need accurate in-network provider directories, and there should be no implied consent for emergency services. Again, I would love to see hospitals like UPMC give accurate estimates of costs for patients. This happens in other countries. It's extremely useful for elective procedures. And what we see in this country is people who try and get estimates, they do get one, and then the bill comes, and it's, again, a lot of our bill of the months. The estimate was $4,000, the bill was $10,000, and the hospital goes, oh, well, that was just an estimate. If that happened at your car repair shop, you would go nuts. But in American medicine, we accept that. Estimates should be accurate and binding. No surprise bills ever generated. Hospitals could manage some of that by making sure that all their staff is in network. And a standard bill in English that patients can read and assess for accuracy. Transparency is all the rage now. There's hospitals supposed to put charge masters up and the charges they accept from insurers up on their websites. Good luck finding that. If you find it, good luck making heads or tails of it. It might as well be written in Greek for the purposes of most patients. You and I, because we're physicians, can probably start to make it useful, but most patients can't. So try it where you can. I mean, UPMC is a big and storied hospital. It's a great place. But like all hospitals in America, business often has too much power, and you as physicians should work together to push back on behalf of your patients. In some hospitals, this is already happening. This is a little hospital in Northwest, in the very northern part of California, Sutter Coast Hospital, and it's owned by Sutter. So, big hospital system. Sutter decided that it would close Sutter Coast OBGYN unit because it was losing money, right? This has become a big trend in hospital systems. If a department is not a profit center or is a loss leader, the trend is, well, we better just cut that out. The doctors at Sutter Coast came together and went ballistic. They said, you cannot close the OBGYN unit. There is nowhere else to have a baby around here for 100 miles. And ultimately they prevailed, because remember, as physicians, you are the ones that bring patients, bring the business into the hospital. If they don't have you, they don't have the labor, they don't have the patients. So make your voices heard for what you think is right. And again, another thing, another business practice that may affect you as you go out into the world of practice is that, ask about when you refer, ask about, well, this is more when a practice is bought up by one of the big chains, which is happening more and more. Ask about what facility fees they're going to add on to your bills. We see doctors who think they're doing a good thing and of necessity need for bargaining power to be part of a big health system, but suddenly their patients' bills for a simple outpatient visit go from $300 to $900, $1,000, and they are not happy with that. But once they're in the door, there's not much they can do about it. Also, those contracts frequently involve non-compete clauses. So what it meant for this particular patient who has prostate cancer, when his physician, a longtime physician, moved from one group practice to another that was just 20 miles away, he could not tell his patient where he was going. The patient went to the office for an appointment, said, "Where's Dr. X?" And they said, "We can't tell you." Now, how is that good for patients? It's good for business, but it's terrible for patients. And again, does your hospital deliver luxury care, or can we develop hospitals that really focus on care, like no-frills hospitals? Last of all, drug prices. We need political action at the state and federal level. We're starting to see that. The Biden administration has once again upped the idea of Medicare drug price negotiation, but many, many states in the meantime are taking matters into their own hands. There are laws against prescription drug price rises in a number, and many states, I think the total is like 7 or 8 now, have applied to CMS to be allowed to import drugs from Canada at lower prices for their residents. And recently, the Biden administration supported that idea. How it will work remains to be seen, but it's just a sad state of affairs that we're reduced to kind of these jury-rigged workarounds for a system that's broken. And my parting message is, do everything you can to stop patients from suffering in business disputes, because often when insurers and providers can't agree on a price, it's the patient left holding the bag, and the patient is the person who can least afford it. So thank you, and I think we have a few minutes for questions now.
All right. Thank you very much for the wonderful presentation, Dr. Rosenthal. First, I have a comment and questions from Dr. Chavez. He says, thank you for a great presentation. Not sure if you could comment about the cost that adds to the healthcare system to have uninsured patients, and how having universal healthcare, all individuals insured, might bring down the cost of healthcare.
That is certainly an issue, and there are certainly, the Biden administration has proposed a public option that everyone, a government-run public option that everyone could buy into if they didn't like the insurance available to them on the commercial market, which I think is a good idea. It basically says to the commercial insurers, unless you deliver more and better for your patients, something more affordable, we're going to backstop this. Now, there have been proposals for Medicare for all, which, because I'm a journalist, I can't say what I favor, but of course, having everyone insured would make a huge difference. And the Biden administration has made great efforts to make the ACA plans more affordable to more Americans. So I'm hoping we'll get there, but just having insurance seems not to help without some mechanism to control prices. So I think universal insurance is a great idea and is morally the right thing to do. I hate the discussion about whether healthcare is a right, because I don't think it's a right. I think it's a necessity. If you're 9 months pregnant and you need to deliver, it's like oxygen and water. Everyone has to have access to it, and the country could do a lot better in that regard.
Absolutely. Thank you. We have a question from Dr. Hoskapal. One of the reasons quoted for high prices in the United States is the price of innovation. Do you think that the United States is the leader in newer and better treatments? And is there a price to pay for that?
Well, we certainly get treatments sooner, the new treatments sooner, and the high prices that new drugs can command in the U.S. are certainly a great incentive for innovation. But I think that's overrated. You don't need. There's certainly BioNTech, that was the originator of the Pfizer vaccine, is from a country where it is in Germany, right, where drugs don't command these high prices. So I like to think that there are many people in medicine, in hospitals, and in device makers and pharmaceutical manufacturers who are still motivated, yes, a little bit by profit, wanting to make some money, but more by wanting to do good. What we get when money is the motivator is, 6 different drugs for MS that all cost many times more what they cost in other countries. And they've never been compared to each other. So we don't even know which one works better, because God forbid a drug maker did a comparative study and found that theirs worked worse, or the cheapest one worked better.
Thank you. And I think we have time for one more question from Dr. Syed. She says, thank you so much for your incredible work. She said, I just turned 50 and I've seen firsthand the backseat doctors have transitioned to. My question is, now that things are the way that they are, how can we as physicians have access to help our patients know what they will need to pay? She says, for example, I am in adolescent medicine, and sometimes when I send gonorrhea and chlamydia testing, I will get the angry call from a parent that they were charged $400. Of course, what can you do after the fact? But if she knew ahead of time, what could we do differently, as we too are kept in the dark?
Yeah, and I think what physicians have to do is to bind together as a community at your hospital, or sometimes, in some cases, for some things nationally, to demand that prices. This is why I want prices on order sheets. I'm sure those gonorrhea or chlamydia tests sent to a commercial lab would have been much, much cheaper. So, and I know doctors hate electronic health records for a million reasons, but one of the business reasons I hate them is that they're often programmed to keep all business in-house, and therefore create a kind of monopoly on pricing. So look outside, because I hear this over and over again, from from physicians, from surgeons, I took out this guy's appendix. I thought I was doing a great thing. And then the 6-week follow-up, he came in and said, hey, doc, I feel great, but I have a $30,000 bill. And, this surgeon said to me, I realized I'd saved his life and bankrupted his family. And so all I can say is physicians together have power, individually feel helpless, but make noise. That's all. I know that's not very satisfying, but I am seeing groups of particularly younger physicians come together for various causes on behalf of patients, because the patients are, they're going to do what you tell them to do is necessary.
That's extremely helpful. We have many, many more fantastic questions, but at this time, we would like to have everyone transition to the meet and greet, and we can get those questions answered there. Thank you.
Okay, I'll see you all there.